Hello guys, good day everyone. I hope you're all doing well. Today we are going to start the mission 200 plus, 1 month, one plan, one goal. And in this, as we are discussed, we are going to discuss all 19 subject rapid revision lectures and also expected series of the Fmge examination. So let's move on to the first subject, our anatomy rapid revision. Okay, so let's start with the most important triangles and structures. Okay, so first here you can see this is the femoral triangle, and in this femoral triangle we have the three types and three sides of the borders. That is very important. What is the first one? The superior border. The superior border is here inguinal ligament. Okay, and next the medial border is the adductor longus. This is the medial border. And next coming to the lateral border, and the lateral border is the these muscle sartorius. Okay, this is the lateral border. These are the important. Okay, these three borders. Superiorly we have the inguinal ligament, and medially adductor longus muscle, and laterally sartorius muscle. And what about the content? So in the content of the femoral triangle is femoral artery and femoral vein and femoral nerve. Along with that, you also have to remember it also consists the genitofemoral nerve. Okay, genitofemoral nerve which will be presented. This is the content of the femoral triangle and their borders. Next, moving on to the femoral sheath. Femoral sheath has divided into the three compartments, guys. Okay, again, this is on the medial side. This is on the lateral side. Okay, see. These are the three compartments that have been divided. Okay. Next, see on the medial side, this is your deep lymph nodes. Okay. Deep lymph nodes. And this is the lateral side, right? This is the lateral side. And in this lateral side, there will be femoral artery. Okay. Here you can see this is the femoral artery. Along with that, genitofemoral nerve, as we are discussed right here. What is the content? One of the content is genitofemoral nerve. Here also we have on the lateral side there is a femoral artery and genitofemoral nerve. And what about the intermediate one? Here you can see clearly this is the vein, right? This is femoral vein, and this is the what? Femoral sheath which will be covering these important structures. Medially the deep lymph nodes, and intermediately there will be a femoral vein, and laterally femoral artery, and another one is the genitofemoral nerve. Next one, popliteal fossa. Okay, in the popliteal fossa, same again we need to remember about the borders and its main contents. Okay, popliteal fossa. In the popliteal fossa there are four borders. Okay, one are on the medial side, that is your semi-membranous muscle. And the lateral side there will be a biceps femoris, and in the lower side, in the medial and the lateral, there is only one muscle that will be presented. Those are your calf muscles, gastrocnemius and gastrocnemius. These both muscles will be present in the calf, and this is the structure. Medially semi-membranous, and laterally there will be a biceps femoris. And next, coming to the popliteal fossa content. Same as usual, there will be a popliteal artery, popliteal vein, and the nerves that you have to remember. What are the nerves present here is the tibial nerve. Okay, tibial nerve, and also common peroneal nerve, and also along with that sciatic nerve. Okay, sciatic nerve is also present. What are the contents here? There will be a three nerves. What are those? Popliteal artery, popliteal vein, tibial nerve, common peroneal nerve, and the sciatic nerve. This is the popliteal fossa and their structures present inside that. Next, moving on to the anatomical snuff box, right? This is your anatomical snuff box. And in the anatomical snuff box, what are the structures that is present, guys? And here you can see. First, let's see the borders. Okay. And in the borders, you can see the main border here is the tendon of extensor pollicis longus. Okay. This is on the anterior side. This structure is the main border for the anatomical snuff box. The tendon of extensor pollicis longus. And on the inferior side, there will be other two tendons. Okay. The smaller tendon here you can see, this is the tendon of abductor pollicis longus. Okay. And other one is the tendon of extensor pollicis brevis. Okay, on anterior side, remember that there will be a longus, and on the inferior side there will be a brevis. Okay, and what is the structure that will be presented? On the thumb side, on the dorsal side, we will be having the radial artery. Okay, same like that, there will be a radial nerve. So what are the contents that is present here? Radial artery and the radial nerve. And if there will be a pain, if the patient is complaining that there is a pain in the anatomical structure, the most common cause is your carpal bone fracture. What is that carpal bone, guys? That is your scaphoid fracture. Okay, scaphoid fracture is the main culprit for the pain in the anatomical snuff box. Okay, next, moving on to what is this defect, guys? This is the test that we are performing for the patient, those who are having the gluteus muscle weakness. So what is this test name? This is your Trendelenburg test. Okay, this is your Trendelenburg test. In the Trendelenburg test, we are going to see muscles of, for example, what are the three muscles, main muscles? That is your gluteus maximus and also gluteus intermedius and gluteus minimus. And in these three muscles, we are going to check. So, what is the nerve innervation for the gluteus maximus? This is your inferior gluteal nerve. Inferior gluteal nerve. And these two are supplied by the superior gluteal nerve. So, these we are going to check for the mainly on the gluteus intermedius and the gluteus minimus. So that we are checking for the patient of the superior gluteal nerve palsy. Okay, this Trendelenburg. What is the Trendelenburg test? Normally, if you see, there will be a no weakness when you hop on one leg in the normal patient. But what happens when there is a problem on the patient? For example, he want to hop on one leg, but there is a superior gluteal nerve palsy. What happens here? The weakness. This weakness will tilt on the normal side. Okay, so the tilting will be seen on the normal side. If there is a nerve palsy, what happens? This will be the tilt on hopping will be affected on the normal side. So this is the mainly seen in the Trendelenburg test. Next, moving on to the what is these two conditions? One here you can see this is the shoulder drop. This is the shoulder drop, and here you can see this is the winging of scapula. And in the winging of scapula, what is the nerve that is involved? So basically here the involved nerve is the long thoracic nerve. This will be your long thoracic nerve. Next, here it is the nerve that is culprit here is the spinal accessory nerve. Spinal accessory nerve. Because this spinal accessory nerve is going to innervate here. This is the trapezius muscle, right? This trapezius muscle, due to the weakness of the spinal accessory nerve, will cause the patient here. You can see clearly the shoulder drop. Whereas winging of the scapula, here the nerve innervation will be longer thoracic nerve. Next, moving on to this structure. What is this structure, guys? Clearly you can see these are your 6 muscles. What is mean by the 6? Okay, these are your rotator cuff muscles. And rotator cuff muscles means only I mentioned that 6 muscles, only 4 muscles. But here you can see these 4 muscles are, what are those? First one is the supraspinatus, right? Supraspinatus and infraspinatus, teres minor and subscapularis. So first, supraspinatus is the most common one to get injured in the rotator cuff muscles. Okay, first thing that you have to remember. And after that, what is the nerve innervation for all these important muscles? So first nerve, supraspinatus and also infraspinatus. These both are supplied by the one nerve, that is your, both are supplied by the suprascapular. Okay, the nerve innervation is the suprascapular. Next, coming to the teres minor. Teres minor is supplied by the axillary nerve. Okay, this is the important question once time asked. So next, subscapularis. Subscapularis is supplied by the upper subscapular. Upper subscapular nerve is innervated here. And there is also another muscle, that is your teres major. And this teres major is not belongs to this rotator cuff muscle. Okay, this is the different one. But what about the innervation for this one? This will be by the lower subscapular. Okay, lower subscapular. And again, remember, what is the most common torn is seen in the supraspinatus muscle only due to damage. And if there is extensive damage, what happens? There will be a suprascapular innervation will be decreased. Next, another question also asked in this topic is that where these muscles are innervated, and all these muscles are innervated in the greater tubercle. Okay, greater tubercle, but except, all are except, that is your infraspinatus, sorry, that is your subscapularis. These subscapularis is on the lower tubercle. Okay, on lower tubercle. That's what, all these muscles are at the greater tubercle, but only subscapularis will be on the lesser tubercle, sorry, lesser tubercle. Next, here another one, that is your cubital fossa. Let's see. In cubital fossa also, the borders are very important. The superior border, that is your epicondylar line. And the medial border is your pronator teres. And lateral border will be the abductor, sorry, lateral border is the brachioradialis. Okay. So the medial will be pronator teres and the superior border will be epicondylar line, and your lateral border is the brachioradialis. And next, coming to the what is the content that is present. How to remember this content? The mnemonic is simple, MBBS. Okay. How? These MBBS will be from the medial side to the, okay, from this is the medial to the lateral side. So what are those structures? First is your median nerve. If there is a any supracondylar fracture, or if there is a damage or laceration in the cubital fossa, the first nerve to injure is the median nerve. Along with that, brachial artery. This is where we are going to take the sample of the, what is that guys? ABG. We are going to extract from the brachial artery. Next, brachial vein. And along with that, this is also important, there will be present of the superficial radial nerve. Okay, superficially the radial nerve will be also present here. So these are the structures and contents that is present in the cubital fossa. And next, moving on to the another triangle, that is your Calot triangle. And in the Calot triangle, what is the first thing that you have to remember? One is the hepatocystic triangle and another one is the Calot triangle. Calot triangle is basically belongs to your bile system. But whereas hepatocystic, it belongs to both the liver and also the cystic structures of the gallbladder. Next, see what happened on the superior border. Here clearly you can see what is this structure. This is the liver. So here you have the inferior border of liver. Okay, inferior border of liver structure. And on the medial side, what is this one guys? This is the right hepatic duct and left hepatic duct. Here you can see this is the common hepatic duct. On the medial side, you will be having the common hepatic duct. And lateral side, the lateral side is the cystic duct, right? Lateral side, we will be having the cystic duct. Next, moving on to the Calot's triangle. Same as here, Calot's triangle is also consist on the lateral side, there will be a cystic duct. And on the medial side, there will be a common hepatic duct. Next, what about the superior border? Here the superior border, clearly you can see what is the artery that is coming from the hepatic artery, that is cystic artery, right? Cystic artery is the present. And what is the significance of the Calot's triangle? When you are removing this gallbladder, you have to take note, when there is a superior border ligation, remember there will be a highly chance of the bleeding if there is a Calot triangle like cystic artery is passing there. So for the surgery cholecystectomy, this is the importance of the Calot triangle. Next, moving on to the abdominal region. And in this abdominal region, you have to remember the three important points. Okay. First, this is the L3 border and this is your L5 border. Okay. Here, these tubercles belongs to the L5 border. And in the L3, what is present, guys? This is your subcostal plane, subcostal line. And this is the transtubercle line, transtubercle line. And coming to the dermatome, this dermatome is the T10. What is that? Umbilicus. Umbilicus is the T10. So these are the 3 points of the abdominal region that you have to remember. Next, moving on to the inguinal canal. What are present in the inguinal canal? We all know that there will be a layers. For example, if you see, this is the inguinal canal. Okay. Assume this as a inguinal canal. What happened? On the anterior side, there will be a structure of the external oblique muscles, and on the posterior side, you will be having the transversalis fascia. Okay, next on the base, this is your base, and in the base, you will be having the inguinal ligament. On the roof, there will be a two muscles is going to form the tendon. What is the tendon? Conjoint tendon. And these conjoint tendon is formed by what structures? Those are your internal oblique muscles and along with that transversa abdominis muscle. Okay, transversus abdominis muscle. So these are the basic structures that going to form the inguinal canal. Okay, here again coming back to here, what are the layers, guys? So this will be going to form your posterior. Okay, the transversalis fascia and transversus abdominis muscles and internal oblique going to form the roof of the inguinal canal. And coming to the on the anterior side will be external oblique muscle. So what is the base for all these structures to sit? That is the inguinal ligament. Okay, that is the inguinal ligament. And what are the structures that is passing from the female and the male? And in the female, the round ligament of the uterus will be passing. And in the males, there will be a spermatic cord that is passing here. And other structures common in both is the ilioinguinal nerve and genital branch of the genitofemoral nerve will be passing here. So common another question is asked in the hernioplasty. In the patients of the hernioplasty, highly risk of which nerve damage? That is your ilioinguinal nerve is going to most commonly damaged. Okay, this is what the basic structure of the anatomy of the inguinal canal. And next, moving on to the Hesselbach's triangle. Here you can see this is the Hesselbach's triangle. In the Hesselbach's triangle, the medially, what is the medially present structure? Here you can see this is the medially, right? And the medially, what is the structure that is passing here, guys? Rectus abdominis muscle, right? This is your rectus abdominis. And along with that, there is an inferior side. Here you can see this is the inferior one. And on the inferior side, you will be seeing the inguinal ligament. And on the superior, this is the superior structure going to differentiate, this is the lateral structure. And on the lateral side, this is going to differentiate us between the, what are the structures? Those are inferior epigastric vessels. Okay, these will differentiate between the both the hernia, direct hernia and the indirect hernia. This is your Hesselbach's triangle. Next, this is the classification of the liver segments. Remember with your hand itself, the thumb that is closed inside is the first segment, and again this will be following 2, 3, 4, 4 and next 5, 6, 7, 8. Okay, these are the structure. This is belongs to the coordinate classification, these liver segments. Once there will be asking like this, they will mark this and ask the question, what is the structure that is going to differentiate? Falciform ligament. And what are the segments that you have to remember? So the first one is the most, that is the caudate lobe that will be present here. and along with that 2, 3, 4, 4, 5, 6, 7, 8. So this way you can remember. Okay, don't forget this liver segment. One direct question can be asked here. Next one, moving on to the mediastinum. What are the structures that is present in the mediastinum? Here you can see this is the first thing that you have to remember, how the mediastinums are divided. First, there will be a divide of the anterior mediastinum and the posterior mediastinum. Okay, so sorry, there will be a superior mediastinum one, and there will be a inferior mediastinum. All this will be belongs to your inferior mediastinum. So let's see the what are the structures that is present in this mediastinums. First, or let's take the superior mediastinum. Okay, superior one. In the superior one, the mostly the important ones that you have to remember is the ascending aorta. Okay, ascending aorta. Along with that, there will be a thoracic duct, and trachea will be passing there, and along with that esophagus. Where there will be a esophagus, you will be also having the vagus nerve. Right? Next, phrenic nerve will be passing, and along with that also the left recurrent laryngeal nerve is also passing here. Left recurrent laryngeal nerve. Along with that sympathetic trunk. Sympathetic trunk also present here. This is the superior mediastinum. Next, the inferior mediastinum. Again, what are those subdivided? Anterior, middle, and posterior. So, on the anterior one, only the two things are present here, guys. One is the thymus gland, and along with that, free fatty tissue of the pericardium. Okay, free fatty tissue of the pericardium will be present here. And next one, middle. And in the middle, you will be having the heart, right? And also phrenic nerve and pericardial tissue. These are the middle mediastinum. Right, here you can see this is the heart that is present. Along with that, the phrenic nerve will be present and pericardial tissue is present here. Last but not the least, this is the posterior one and very important one. Okay, and this can be asked where questions can be asked here. What are those? Esophagus. Okay, this is your esophagus. And again, what I said, esophagus, there will be a vagus nerve. Right? Vagus nerve will be presented. And another one is the descending aorta. Right? Descending aorta. And other structures that is pierced from the superior mediastinum, like sympathetic trunk, will be also having here. Sympathetic trunk. Along with that, there will be an inferior vena cava and thoracic duct. Thoracic duct. These are the structures that is present in the posterior. Only nerve that is present here is the vagus nerve. So this is the mediastinum and their classification. And next, moving on to this diagram. Based on this diagram, what did you understand, guys? This is the lung hilum, right? Lung hilum. In the lung hilum, this is your right side lung and this is the left side lung. Okay. What are the structures that is present in the right side of the lung hilum? So they will be present like this. B, A, B, V. Okay. Remember this way. What is this on the right side of the hilum? Here you can see first thing is there will be a bronchus and there will be a vein, and again there will be a bronchus, again artery. Okay, this way it will be presented. So on the up to down, the first one is the bronchus structure. Okay, this is the bronchus structure, and this is known as a hip arterial. Hip arterial. Okay, next, what is present here? This is your artery. Okay, pulmonary artery, and again there will be a bronchus here. This will be hip arterial. Okay, below the artery, the bronchus presented here, and pulmonary vein. Okay, these are the structures that is present on the right side of the hilum. Next, on the left side of the hilum, only the artery, that is your pulmonary artery, and next one is the bronchus below the artery and pulmonary vein. This is how present in the left side of the hilum, and whereas on the right side The first epiarterial bronchus, pulmonary artery, and another bronchus and another vein. So this is how the hilum structures will be presented. And next question, we have to remember this one, the neurovascular bundle, where this neurovascular bundle is present. So these neurovascular bundle, which will be consisting of the arteries, okay, intercostal arteries, okay. What are those intercostal arteries? Okay, the branches of the intercostal artery and also intercostal vein and intercostal nerve. These are the structures that is present on this neurovascular bundle, where this neurovascular bundle is presented. So if this is your rib, okay, if this is your rib, there will be presenting of these structures at this place. So lower border of the rib, it will be presented. Lower border of the rib, it will be presented. But why it is important? So when you are doing the needle thoracostomy, you have to do at the upper border of the rib. Okay, always remember, you have to choose the upper border of the rib. Never go behind the lower border, because you may damage the intercostal artery or the vein or the nerve. So going to the openings of the diaphragm and structures and passing through it. So let's see, they are the three main structures given the three different levels. So the first level will be T8, and second level T10, and third level is the T12. Here you can see these are those places. So the first one is here. You have to remember the T8. So this is the T8. Okay, this is where the T8 will be present here. Again, this is your T10 and this is your T12. Okay, guys. So let's see what are the structures that is present in the T8. So first, there will be a intravenous inferior vena cava. Along with that, the right side of the phrenic nerve branch will be present here. Okay, right phrenic nerve branch present here. Next, here you can see esophageal hiatus. So the first one here present is the esophagus, and also remember, where there will be a esophagus, there will be a vagus nerve. Along with that, there will be a left gastric artery. Okay, left gastric artery is also present here. Next, aortic hiatus. In the aortic hiatus, there will be a aorta. Along with that, there will be a thoracic duct. Thoracic duct also present here. Another vein that is passing here is the asgius vein. Okay, asgius vein is also present here. Next, there will be a question that what is the main innervation of this diaphragm muscle? So the main muscle for this is the main innervation nerve supply is the phrenic nerve. Okay, phrenic nerve. And how can you remember this phrenic nerve? Nerve roots. Phrenic, right? So remember this like as a phrenic nerve. Okay, phrenic nerve. What are the nerve roots that are present here? C3, C4, and C5. So 3, 4, 5. Phrenic nerve. Remember that way as a mnemonic. Okay, this is the main supply for this muscle. And this muscle is very important for the both inspiration and expiration. Especially for the inspiration, this muscle plays the main role. Right? This is your structure and diaphragm openings. Next, moving on to the heart. So here you can see this is the arterial supply of the heart. What are the arteries? The main arteries on the anterior side, if you see, there is a right coronary artery and left coronary artery, which will be giving the branches to the, this is the left main coronary artery, left circumflex artery, and left anterior descending artery, and another branches. The right coronary arteries are mainly going to supply for your SA node and also AV node, and all the right marginal branches will be supplied by the your right coronary artery. And if you see on the posterior side, so the main posterior descending artery is also right coronary artery. So mainly on the posterior side, most of the patient will be right dominance only. Very rarely we see the left main coronary artery branches dominantly. Okay, this is the arterial supply for the heart. So where we are going to place the chest leads, guys? We are going to place the chest leads this way, right? This is the way. On the horizontally, we are going to place V1, V2, V3, and V4, V5, and V6. This is how we are going to place. Another chest leads, another leads that we are going to place is the lead 1, lead 2 and lead 3. Okay, and also augmented leads the V foot and also AV left and augmented lead AV right. These are the branches. But what is the arterial supply? When you are checking, you are actually checking for the thrombus formation that is damaged and cause the myocardial infarction in this patient. So in this ECG, you are checking what are the main branches that is involved. So the first branches that you have to remember, what can be the artery that is involved here is the most common artery is the involved in the MI is the LADA. What is this LADA? Left anterior descending artery, right? So see here. So inferior, these all are belongs to your inferior. Okay, these are your inferior. AVF, third lead and the second lead. These three are your inferior leads, and inferior leads are supplied by the RCA. So right coronary artery is going to supply here. Next. Another one is your anterior side. Okay, anterior-septal. So this is the anterior side, and these anterior-septal leads are supplied by your LADA. Okay, these are your anterior septal. Anterior septal is supplied by the LADA artery. And next one and the last most important one, this is the lateral one. Okay, these are your lateral side, and lateral side will be supplied by the left circumflex artery. Okay, left circumflex artery. And again, revise again once with me. What are the leads that is present here, guys? For the LCA, what are the leads here? We have V5 and V6 and lead 1. Next, LADA. For the LADA, what are the leads we have seen? V1, V2, V3 and V4 because anterior septal. Next, inferior, so RCA is supplying which leads? Lead 2, lead 3 and AVF. These are the three leads that is present for the RCA. So this is the mainly that you have to remember from the ECG and their arterial supplies. Next one. Here you can see this is the structure that we are looking here is the urethra and their structure. So urethra is subdivided into the 4 types. One is the penile urethra and bulbar urethra and membranous urethra and prostatic urethra. So if there is a trauma in this patient, especially what are those structures? The membranous urethra damage or bulbar urethra damage. Which is most common in this? The most common is the bulbar urethra fracture. So if there is a membranous urethra damage, the main reason will be pelvic fracture. Okay, especially pelvic fracture that can cause the membranous urethra problem. Here directly it is going to damage the structure of the urethra. Next, in the bulbar urethra, this is the straddle injury. Unfortunately, if there is a straddle injury, the patient will suffer from this bulbar urethra. Where the bulbar, especially this region, right? The bulbar urethra will be causing damage. And what is the main question here? The question is where this urine is going to stagnate. So, in the membranous urethra, it is going to form in the prostate. Okay. Here, if it is damaged, it will leak upside, right? So it will be leaking into the prostate. Along with that, and if it is leaked also, it will be going to leak into the deep peroneal pouch, right? Deep peroneal pouch. And you can't see the scrotal hematoma. So the scrotal hematoma is not present. So no scrotal hematoma. Whereas bulbar urethra, first thing it is going to cause in the superficially. Okay, so it will going to leak into the superficial peroneal pouch. Superficial peroneal pouch and also anterior abdominal wall. Okay, anterior abdominal wall also it is going to present, and there will be a scrotal hematoma. Scrotal hematoma is present. Okay, scrotal hematoma is present here, and in both these sides, peritoneum, does peritoneum is going to involve? No. So there is no involvement of the peritoneum. Only if there is a bladder injury, okay, this bladder is damaged, then only involvement of the peritoneum is seen. But it does not involve the peritoneum in both the membranous or the bulbar urethra damage. Okay, that is the important thing that you have to remember. Next, this is the circle of Willis. In the circle of Willis, you have to remember the what are the branches that is present here. The main arteries are the internal carotid artery, and another one is the basilar artery and vertebral artery. So let's see. In the internal carotid artery, the main branches are anterior communicating artery, anterior cerebral artery, ophthalmic artery, and anterior choroidal artery, middle cerebral artery, and posterior communicating artery. These all branches are going to form from the internal carotid artery. Next, coming to the basilar artery. The basilar artery, the branches are your posterior cerebral artery, superior cerebral artery, and pontine arteries. Okay, and also there will be a artery of the anterior inferior cerebellar artery. Next, coming to the vertebral artery. What are the main branches of the vertebral artery? In the vertebral artery, you are having the anterior spinal artery. Here you can see anterior spinal artery and posterior inferior cerebellar artery. Along with that, there will be a posterior spinal artery. Okay, along with that, there will be a posterior cerebellar artery also. Sorry, posterior spinal arteries, anterior spinal artery and posterior spinal artery. And also vertebral artery is giving branch to the basilar artery. Okay, this is also going to involve for the basilar artery. All right. And another thing that you have to remember, anterior spinal artery is only one branch, whereas posterior spinal branches are two branches. And what forms the circle of Willis? So the circle of Willis is formed by the only four structures. What are those four structures forming the circle of Willis? One is the posterior cerebellar artery, along with that posterior communicating artery. Along, and other one is the anterior cerebellar artery and also anterior communicating artery, which will be forming this structure. Okay, this is the circle of Willis, which will be formed by the anterior communicating artery. Here you can see anterior cerebellar artery, posterior communicating artery, and posterior cerebral artery. Okay, this is the structures that is present in the circle of Willis. Next, moving on to the nerves. What are the nerves that you have to remember here? All the cranial nerves important. So the olfactory nerve, the main function is the smell. Optic nerve, vision. And the eye movements, extraocular movements. These are by the oculomotor, trochlear, and the abducens. And next, trigeminal nerve, the three sub-branches will be given. The V1, V2, V3. And the facial nerve, for the facial muscles, auditory, this is your vestibulocochlear nerve, and the glossopharyngeal, ninth nerve, and vagus nerve is the 10th, and 11th one is the hypoglossal, and 12th one is the spinal accessory nerves. And how to remember this? So the sensory pathway. So the sensory supply, mostly the sensory supply is given by the first of olfactory and optic and also vestibulocochlear. Next, motor. Motor is your the extraocular muscles, the third now oculomotor, and also abducens, and there will be a other one trochlear. These are the three motor. Along with that, hypoglossal and spinal accessory nerves. And parasympathetic nervous system, that is connected with the third cranial nerve, seventh cranial nerve, and ninth and 10th cranial nerves. These are present in the parasympathetic nervous system pathway. Next, another important topic here, the skull foramina. In this skull foramina, remember the first olfactory nerve that is coming from the cerebriform plate, and the optic canal. Here you can see this is the optic canal. In the optic canal, there is a cranial nerve too. Along with that, ophthalmic artery is also coming here. Next, there is a C. This is the one. Here you can see the superior orbital fissure. Here, all main nerves like third, fourth, fifth, and sixth, that is coming from here. Superior ophthalmic vein is also passing here. Next, the D. This is the foramen rodentum. Here, the fifth second branch, trigeminal second branch is coming from here. And also, the foramen ovale, just beside to that, here, the fifth third branch, the trigeminal third branch is coming from the foramen ovale. And here you can see this is the internal acoustic meatus. Internal acoustic meatus, vestibulocochlear nerve, that is coming from here. Along with that, there is a facial nerve. Both these are coming from these structures only. Remember this way, the internal auditory artery is also coming here. Next, here the jugular foramen. Here the jugular foramen, internal jugular vein. Along with that, 9, 10, 11. These three nerves is also coming from this longer jugular nerve foramen. Next, hypoglossal canal, the name itself telling it is passing through by the spinal accessory nerve, not the hypoglossal nerve. Okay, the name, it is a mesnomic. Okay, the hypoglossal canal will be passing the 12th cranial nerve. Okay, next, foramen spinosum. Foramen spinosum is going to pass the meningeal branch. This is there will be a third branch of the branch also, along with that middle meningeal artery. So if there is a middle meningeal artery damage, there will be a high risk of epidural hematoma. Next, carotid canal, internal carotid artery, foramen magnum. So 11th ascending of the hypoglossal nerve will be seen here, along with that vertebral and the spinal vessels. Okay, this is the structures that you have to remember here. This is the foramen magnum, right? Vertebral artery and also 11th digit. This is the only one that is seen in the posterior side. All these are the arteries that you have, are nerves and the arteries which are passing through these canals are very, very important, guys. Next, moving on to the pharyngeal arches. So in the pharyngeal arches, rather than remembering all the muscles and important structures, remember the nerve and the artery. Okay, so the first arch, in the first arch, there will be a mandibular artery. Okay, mandibular artery. Along with that, there will be a maxillary nerve. Maxillary nerve. And in the second arch, there will be a stapedial artery. There will be a stapedial artery and facial nerve. And third one, hypoglossal, glossopharyngeal nerve, and along with that, carotid nerve, carotid artery. Okay, this is the third pharyngeal arch. And on the fourth one, arch of aorta, and also superficial laryngeal nerve. Superficial laryngeal nerve is present here. Next, on the sixth arch, there will be a ductus arteriosus. Okay, ductus arteriosus. And right and left, both pulmonary trunk will be present here. Okay, both pulmonary trunk will be present here, especially arteries that is passing here. And the nerve will be recurrent laryngeal nerve. Recurrent laryngeal nerve. These are the important structures, arteries and the nerves for the pharyngeal arches. Next, the topic is, here you can see this is the tongue and their nerve supply. So first 1/3 of the, so this is the 1/3, right? So first 1/3. So the first 1/3 is supplied by the two nerves. One is the lingual nerve and another one is the caudate tympani. So the lingual nerve, this is going to give for the general taste. Okay, general taste for the first. And caudate tympani is mainly for the taste sensation. Okay, lingual nerve for the general sensation. These two thirds are supplied by the V3 trigeminal third branch lingual nerve, and also this is the caudate tympani nerve. Okay, that's the first one. Next one, on the 2/3, this is the 2/3 of the part, and this is the 1/3 of the part is going to supplied by the glossopharyngeal nerve. And the base, this is the base which is supplied by your vagus nerve, internal branch of the superior laryngeal nerve. This is going to be the supply for the base of the tongue. And what about the muscles? All the muscles are supplied by the hypoglossal nerve, except is the palatoglossal. Except is the palatoglossal. This is the nerve that is present here, palatoglossal. Next, here you can see this is the hypoglossal nerve injury. This is the hypoglossal nerve injury. And in the hypoglossal nerve injury, what you can see, guys, especially this is the normal side. Okay, here you can see this is the stria that you can present here. So what happens? This is the where the nerve damage, the nerve is damaged here. So what happens? The tongue will be cornered to the normal side. Okay, because there will be intact of the muscle structures here that is pulling this side. So normally the tongue will be cornering to the normal side. That is seen in the hypoglossal nerve injury. Okay, next, mastication muscles. Remember what are the mastication muscles? Mastication muscles are your lateral pterygoid, lateral pterygoid, and also medial pterygoid, masseter muscle, and along with that temporalis muscle. These are the four muscles that is important for your mastication. Next topic, neural tube defects. So we have the first one anterior and other one is the posterior neural tubal defects. On the anterior side, when these anterior cranial nerve defects will be coming, when there is a development, the development is stopped by the 25th intrauterine life or third week, 25th day. Okay, 25th day or third week. On the posteriorly, the 28th day or fourth week here, as per the anterior cranial nerve defects and the posterior cranial nerve defects. So in the anteriorly, the most common one that is associated with the anterior side is the anencephaly. This is the most common anterior side. And overall, if they ask overall, that is your spina bifida. Overall, most common, all the neural tubal defects is the spina bifida, but only anterior, that is anencephaly. Okay, anencephaly. In the ultrasound, what you will be going to see? Frog sign, frog face sign that you are going to see, right? Next, posterior, the most common one is the spina bifida. Spina bifida. Most severe one is your meningocephaly. Okay, myelomeningocele. That is the most commonly seen. What is the culprit of this one? The culprit is the multifactorial. Okay, multifactorial inheritance. Multifactorial inheritance. And in this multifactorial inheritance, what can be given for the prevention? Folate. Folate can be given. How much? At least 4 mg pre-conception. Okay, pre-conception. 3 months before the pregnancy, you have to start this folate therapy. Okay, this is what the cranial nerve defects. Next, what is this structures, guys? These structures are these pictures that is showing this patient is suffering from omphalocele, right? This patient is suffering from the omphalocele, and this patient is suffering from the gastroschisis. Gastroschisis, and omphalocele is associated with the covering. So, because it is omphalo coming from the umbilicus, and gastroschisis no covering, because it is not coming from the umbilicus, it is actually coming from the anterior abdominal wall. Okay, see, this is how it is going to present. So both will be high risk of necrosis to the vessels. But which is more severe, guys? The more severe will be that is omphalocele, because it can herniate the liver also. And mostly the omphalocele will be associated with the another genetic conditions, whereas gastroschisis not associated with the other conditions. So both what we are going to treat, and first as usual immediately cover the structures and elective surgery. Okay, not immediately, we are going to process for the elective surgery. Next topic, here you can see the epithelium, and in the epithelium that you have to remember the four important: simple squamous epithelium, simple columnar epithelium, and pseudo-stratified columnar epithelium, and stratified squamous epithelium, and transitional epithelium. Let's see the important examples that you have to remember. Simple squamous epithelium is present on the air sacs of the lungs. At the alveoli level, you are going to see the simple squamous epithelium. And also blood vessels. the endothelium is also covered by the one layer, that is the simple squamous epithelium. Next, simple columnar epithelium, which will be containing this cilia. This is presented in the ciliated structures like bronchi, uterine tubes, uterus. These are the mainly, and also digestive tract, bladder, that will be present of the simple columnar epithelium. Next, pseudostratified, mostly this is present in the trachea and all the upper respiratory structures like bronchi and branches also. You will be seeing this pseudostratified columnar epithelium. Next is stratified squamous epithelium, present in the esophagus, mouth and vagina. This is going to be present in the stratified squamous epithelium. Next, transitional epithelium is present in the bladder, urethra and ureters. This is present in the transitional epithelium. Okay, these structures and their important places is very, very important. Next, moving on to the upper nerve palsy and lower motor palsy of the facial nerve. Okay, facial nerve, seventh cranial nerve damage. So, first you have to check what is the difference between this upper motor nerve. Where it is coming, this lesion is on the contralateral side. This is the right side and this is the left side. So, if there is a damage on the upper motor neuron, so on the contralateral side, you will be seeing the effect, especially only the lower half of the face. But on the this one, this is your lower motor neuron, and lower motor neuron will be ipsilateral only. If there is a damage on the same side, so there will be damage whole face, whole one side of the face will be involved here. Okay, so let's see the difference. So upper motor neuron, the lesion will be having the contralateral. Okay, contralateral. And what happens? There will be a sparing, the lower face only involved. Lower face will be involved and forehead is spared here. The difference is forehead is spared here. On drooping of the lesions, no drooping of the lesions will be seen. Eyelids drooping is not seen, right? No drooping will be seen here. And whereas lower motor neuron, it is ipsilateral, right? It is ipsilateral. On the ipsilateral line, you are going to see what are the structures, guys. Whole face is involved, right? Whole face is also involved. Along with that, forehead is also involved in this patient. Drooping of the eyelids, dryness is also seen in this patient. This is the nerve palsy of the facial nerve. And next, the pulse points. Pulse point can be also asked in the examination. First, this is your brachial artery at the cubital fossa, popliteal artery at the popliteal fossa, radial artery at the anatomical snuff box, femoral artery in the inguinal canal region, and dorsalis pedis on the dorsum of our foot, and posterior tibial artery on the posterior side of the foot. So these are the main places that you have to remember. Carotid artery in the neck region, and facial artery at the region of the jaw, and temporal artery present on the temporal bone of the place. So these are the structures and artery pulse spots that you have to remember. Next, the joints. Joints are divided into the three types. What are those joints, guys? The three types of the joints we have. First one is the fibrous joints. So first one is the fibrous joints, and second one is the cartilaginous joints, and third one is your synovial joints. Okay, these are the three joints. And fibrous joints, completely no movement. Okay, completely no movement. So on the cartilaginous, there will be a slight movement, and synovial, so there will be a complete range of motion is seen in this patients, in this structure, synovial joints. So let's see what are those examples. These are the fibrous joints. Okay, the types of the fibrous joints is the sutures and syndesmosis and also gomphosis. These are the three types of the fibrous joint. What are the examples? The sutures is going to be seen. The coronal suture, parietal sutures, and all the sutures that is present in the skull, that is your sutures of the fibrous joints. And syndesmosis is going to be, so this is the structure where the joint will be presented. And there are two examples that you have to remember. One is the tibiofibular and radioulnar. These are the two joints that is present in the syndesmosis. And third one, gomphosis. Here you can see this is the one. So the tooth root, the root of the tooth is your Mainly gomphosis. No movement. If you observe, you can't see the movement of the sutures. You can't see the movement of the radio ulnar or the tibiofibular. And also our root also you can't see the movement. Next one, cartilaginous. This is the primary cartilaginous. This is the secondary cartilaginous. Primary cartilaginous are united by the hyaline cartilage, whereas the symphysis or the secondary cartilage is connected by the fibrocartilage. What are the examples? So the first, these primary cartilaginous, there will be a epiphyseal plate. So the epiphyseal plate is formed by the, in the children especially, that is by the synchondrosis primary cartilaginous. And the another one is the costosternal region. Okay, so the costosternal joint. Costosternal joint that is connecting the first rib and the sternum, that is your synchondrosis. Next, symphysis. In the symphysis, pubic symphysis, the one example that is going to connect the both pelvic girdles, and also both vertebrae is connected by this fibrocartilages, that is your intervertebral disc. These are the two structures that is present here. And next, coming to the synovial joints. In the synovial joints, the first ball joint, hip joint, and also it is going to have the shoulder joint, right? Shoulder joint also present here. This is the one. And another one is the incus and stapes. And next, coming to the condyloid, and here in the condyloid, there will be a between the carpal bones, right? MCP, metacarpal joints, and also knee also present here, and temporomandibular joint is also connected by the condyloid joint. Next, plain plate. What happens here? Interphalangeal, okay, interphalangeal carpal joints, and also interphalangeal tarsal joints. Okay, here you can see these are the tarsal bones and carpal bones, which is connected by the plain joint. Next, moving on to the saddle joint. In the saddle joint, you will be having the sternoclavicular joint. Along with that, also you will be having the these one first MCP and the carpal bones. Okay, this is also present in the saddle joint. And the hinge joint example is your elbows. And pivot joint, you will be having the C1 and C2. That is your atlantoaxial joint. Next topic, brachial plexus. In the brachial plexus, at least you have to remember not on all the entire the brachial plexus, but at least remember these nerve roots. Okay, so the first one is the axillary nerve, and the axillary nerve roots are the C5 and C6. Along with that, suprascapular. Remember, we have discussed suprascapular is going to supply infraspinatus and the supraspinatus. This is also belongs to the C5 and C6. Next one, your musculocutaneous. These musculocutaneous is going to supply again C5, C6 and also C7. Along with that, longer thoracic nerve. Okay, long thoracic nerve. This is also going to supplied by the C5, C6 and C7. And next one is the ulnar nerve. And ulnar nerve is supplied by the C7, C8 and T1. Next one is your radial nerve. And in the radial nerve, the nerve roots are the C5, C6, C7, C8 and T1. And same as your median nerve is also going to supplied by the C5, C6, C7, C8 and T1. So these are the nerve roots that you have to remember. Guys, okay? This is very important. Next, moving on to the another topic, Erb's palsy and the Klumpke's palsy. What are the nerves that is involved here? C5 and C6 and here C8 and T1. These are the two that is involved in this patient. How the defects are seen? This is actually upper trunk, right? And this is going to involve the lower trunk. And mainly if you see, this is actually happened due to shoulder dystocia. And this can be happened due to the hyperextension of the hand. And what are the defects where you will see? Here you are going to see the waiter tip. Like this, the patient is giving like a tip or the policeman tip. And this is the claw hand, right? Here you can see clearly this is the claw hand. And what are the structures that is involved mainly here? One is your axillary artery, right? We just now seen what are the nerve roots? axillary artery, and also suprascapular, and also musculocutaneous nerve is also involved here. Next, along with that, what is the defect that you can see here? The arm, how it is adducted, right? It is adducted towards the midline, and also medial rotation or the internal rotation, and along with that pronation, this is the pronation, and elbow extended, right? Elbow is extended. This is how the defect is seen in the Erb's palsy. Whereas claw hand, partially the hand will be clawed. What happens this claw hand is MCB, the metacarpal joints are going to be hyperextended. And next, the proximal and the distal interphalangeal joints, these are going to be flexed. Okay, this is causing the claw hand. Along with that, Horner syndrome, because C8T1 is going to supply for the first, the cervical branches also. So that's why what happened, the Horner syndrome is also seen in this patient. How the Horner syndrome will be going to include, guys? Ample. Remember this as a ample. What is the mnemonic for the ample? Anhydrosis, and meiosis, ptosis, and also loss of ciliary reflexes. And along with that, anophthalmos. This is commonly seen in the Horner syndrome. Next, coming to the other nerve branches, this is what known as your ape thumb deformity. This is ape thumb deformity seen in the median nerve damage. Okay, median nerve damage, especially supracondylar fracture. Next, coming to the partial claw hand. This is the partial claw hand seen in the ulnar nerve palsy, right? This is seen in the ulnar nerve palsy. Next, this is the wrist drop. And this wrist drop is seen in which condition, guys? Radial nerve palsy, right? This is seen in the radial nerve palsy. Next, this is the foot drop. Foot drop is seen in the patients of the common peroneal nerve damage. Especially your fibula fracture. Okay, fibula fracture. Next, the nerve supply of the hand. So this is your anterior side, and this is on the posterior side. The main three arteries are going to supply here. So on the anterior side, all the lateral side of the will be going to supplied by the ulnar nerve, and medial side is going to supplied by the median nerve. And on the posterior side, radial aspect. So the radial nerve, the first 1/3 are supplied by the radial, and second, the lateral again here also supplied by the ulnar nerve. And next, only the tip, these are going to supplied by the median nerve. Next, here another picture, here you can see this is the humor, right? This is the humerus, and in this humerus bone, this is known as the surgical neck. This is the surgical neck. If there is a surgical neck, what is the structures are present here? Especially the posterior circumflex artery. Posterior circumflex artery is present here, along with that axillary nerve. So if there is a fracture or if there is a surgical any problem, that will cause the posterior circumflex artery damage and also axillary nerve damage. So this will cause this condition, axillary nerve palsy. This is the groove. This is the spiral groove. And in this spiral groove, what are the structures that is present here, guys? Profunda brachis, profunda brachii arteries, along with that radial nerve. Okay, radial nerve. And what is this specially? This is the shaft. This is the shaft. If there is a fracture in the shaft, especially the spiral groove, that is going to cause the radial nerve damage, wrist drop. Wrist drop is seen here. Next, Another one, last topic. This is the, what is the structure? This is the clavicle. And the clavicle, if there is a clavicle damage, especially due to the trauma, the most common junction and most common overall the fracture is the clavicle fracture. And what is the junction, guys? 1/3 of the lateral and 2/3 of the medial clavicle is involved in the clavicle fracture. And this specific thing is the, this is the first to ossify in our body at 5th week of intrauterine life, and last to complete its ossification. Last to complete its ossification at 25 years of age. Up to at 25 years of age. This is the, basically we have overviewed of the nerve injuries. Next, the last one is the dermatomes. This is the upper body of the dermatomes and this is the lower body of the dermatomes. Just see the important ones. Okay. So the first one, here the trapezius and the neck muscle that is supplied by the C3 nerve root. And next, the hand, the C5, and it is on the deltoid region, and the thumb is supplied by the C6 and the little finger is supplied by the C8, and remaining hand, the palm, that is supplied by the C7. Same as here, C6, C8 and C7. And coming to the lower trunk, so here the posterior side, S1 is the major part of the posterior side, whereas on the anterior side, L5 and the L4 is the main part of the leg. Okay. And also coming to the foot region, L5 on the anterior side, S1 on the lateral side. And here also S1 is the major one supplying in the back side. Again, coming to the this side, in the femoral region, medial femoral region is by the L3, and posterior side, it is lateral side is supplied by the S2. Okay. And umbilicus, again here you can see this is by the T10. Okay. These are the dermatomes that you have to remember. Just see the overview, and here completes our complete anatomy rapid revision, which we are focused mostly on the PYTs and very, very important and expected topics. Please do revise and join the Telegram group so you can find the annotated PDF. And those who are interested, please join the course. Okay, this course we have launched recently, Mission 200 plus, 1 month, 1 plan, 1 goal. And we are going to provide the Tribular Edition 2 and 100 important topics, 100 one-liners PDF. Along with that, daily there will be a quiz in the Telegram group, and also many other important lectures and also expected topic lectures. So thanks for joining. Those who are new to this group, please do subscribe and share with your friends. All the best and happy learning. How to access or how to join, and you have to we are going to upload the Google form, and through that Google form you have to make the payment and also upload your details as soon as possible. And after that, please do text me in my Telegram ID so that I can add you back in my group. Okay. And the price, the current price for the slots we are booking from tomorrow, that is 299 only. Okay. So make the payment and fill the Google form and text me in the Telegram, and we will be joining you in the group.